Well, good afternoon. It's a very great pleasure to be here. I'm going to talk about these three problems. It's called the Iron Triangle because nearly all systems of healthcare try to achieve all three and none succeeds. And virtually every system throughout the world is reorganising itself to try and achieve these different objectives. So, whilst we're chatting over lunch, I was explaining that in England the government feels that this centralised system is not working too well, so looking to devolve responsibility to local government. And in Sweden you would think that you're going to shift up from local government towards centralisation. So we keep on playing around with these different systems. About 15 years ago, with Elias Mosialos, I started the European Health Policy Group. And our view then was that since all systems in Europe try to achieve these three objectives, we ought to be able to learn from each other. And we've had very interesting discussions there, and I see this as a fantastic opportunity. I hope you can learn from me, but I hope also to learn from you in looking at evidence as to how we achieve these three different objectives. Natural experiments is the difficulty we have when we look at policies for healthcare, is that governments on the whole don't like to have controlled experiments. There's a very famous health insurance experiment in the United States, the RAND experiment in the 1970s, 1980s.
The Newhouse experiment?
The Newhouse, where they randomly allocated these different insurance packages. And I still find it extraordinary they're actually able to do that. I'm not sure they'll be able to do it now. So basically, the natural experiment is where you've got countries with similar systems and then there's a policy difference. You can begin to see what the impact of the policy difference is. So the three things I'm going to look at is what about equity and cost control? And the natural experiment there is one that one of the best health economists in the world, Gwyn Bevan, did, living in Canada, comparing Canada with the United States. Then there's work I've been doing with a Swedish scholar, comparing England and Sweden in terms of equity and access and outcome. This is the distribution of healthcare within the system and outcomes in terms of health. And then there's how you improve performance, looking at models of governance. This is markets and using performance measurement. So if we start out with the Iron Triangle in healthcare, these are the three objectives that we try to achieve in systems of healthcare. Cutler, a Harvard economist, took the view that one of the issues that happens is through equity and universal coverage, the costs go up. You try and tackle cost control that then damages performance. You try and change performance, and so you cycle around these objectives. But one of the questions is, does equity really make cost control more difficult? And this is what Evans did, this natural experiment in the United States and Canada, where these two countries had very similar systems in terms of how they organised healthcare and how they paid for healthcare. And then from the 1970s, Canada wanted to tackle the problem that the United States still struggles with as to how you can have equity of access to healthcare without finance being a barrier to pay. So they changed to the single payer system, universal and free, but they didn't change the way healthcare is delivered. So this is a very interesting contrast because all they did was to change the financial system. Now, if you look at this shift and you said which system should be better to be able to control the costs of healthcare, then conventional microeconomics, which is the target of Bob Evans' tirade about this
for 30 years,
is that this focus on the US system, that you get cost consciousness and cost control by looking at the patients and getting them to pay for healthcare, is completely the wrong target. But you would expect conventional microeconomics, as the US, will be much better able to control the cost of healthcare because it's free in Canada and they cover everyone, and economists typically get deeply upset about anything being free because it leads to massive overuse. And the United States only covers some of the population and you pay user charges. Now, the outcomes, as we all know, was not as conventional microeconomics predicts. Canada's been much better able to control the costs of healthcare than the United States. And Evan's argument is that they didn't set out to achieve cost control, they set out to achieve equity. Then having moved to a single payer system, they then discovered they're in a very good structural position to control the costs of healthcare. And the reasons for this success, he says, is because the government, as a single payer, is in a much more powerful position to control the supply of healthcare and costs of healthcare than if you have fragmented insurance systems. And so that's the key to achieving cost control. So when we're in periods of austerity and people talk about we can't any longer afford a single payer system, the evidence suggests that's wrong. This is the best way of actually controlling costs of healthcare. And obviously you need to tackle issues on the supply side. This is a comparison of, this shows Canada and the United States, and it also shows England and Sweden. And what's interesting is that these countries have very different systems of organising and delivering healthcare, but very similar paths in terms of spend and percentage of GDP, with the United States, of course, being the odd man out in many international comparisons. So this, I find this actual experiment very interesting, as it suggests that a key element in cost control is the single payer system, universal coverage, and having free access to healthcare doesn't actually undermine your capacity to achieve cost control. I'm now going to talk about work I did with Mio Fredriksson, who's from Uppsala, looking at equity and access and outcome for England and Sweden. This relates to Gustav's paper, but it's nothing like as profound as Gustav's paper. But in terms of equitable issues, I mean, the different positions you might take is that a libertarian position is, an extreme libertarian position is you wouldn't have any state involvement at all. But if you were to have state involvement, what you do is you create opportunities of equity of access to healthcare. A Rawlsian position, which focuses on the least disadvantaged, would direct you to look at how you can achieve equity in health outcomes. A utilitarian, where health economists are, and Gustav talks about the cost-effectiveness analysis, is you get into this question of the equity-efficiency trade-off, which is that it's much more efficient in terms of, if you look at the benefits you get from intervention and the costs, it's much more efficient to treat the better off than the underprivileged and disadvantaged typically. And what we find is prevention widens health inequalities. I'm aware that there may be huge debates about this. I have only 40 minutes, so I'm going to go on. Now this is Julian Tudor-Hart on his website has his picture of him doing the tango. He says he can't actually do the tango, he does this in his dreams. But it's a very nice picture. And he wrote this paper with a great title in 1971 called The Inverse Care Law, in which he argued that typically what happens, of course it isn't just in healthcare, but typically in many public services, the way resources are allocated is you get very high levels of resources where there's low need, and where the need is greatest, you have very low levels of supply. And this is my famous namesake of an Gwyn Bevan who created the National Health Service, and I've yet been able to prove I'm related to him, but I'm still working on it. And he identified these three elements of the inverse care law at work before the NHS was created, about financial barriers to access and the distribution of GPs and hospitals, exactly following this inverse care law, that they were least available where they were most needed. So the political settlement did tackle two of these. Access was free, financed through taxation, and for general practitioners this problem, they tried to solve the problem of inequities through what was called negative direction. I actually was a member of the committee that made these decisions, and what you did was to stop doctors going into what was seen as over-doctored areas. So you'd force them to move into other areas. It wasn't forcing GPs to go into areas where they didn't want to go. You just stopped them going to areas that were relatively over-doctored. And that had some success. As you see, there's still problems in the equitable distribution of GPs. But the thing they did not tackle at all, which I see as part of this political settlement with the Lord Moran and the Royal College of Physicians, was to deliver the NHS. They got the hospital doctors on side in the face of opposition from the British Medical Association representing the GPs. And they didn't do anything about inequity in hospitals. they continued to fund them in terms of what the funding was. So if you looked at where things were 30 years later, hospitals that had been very well funded in the 1940s will be relatively well funded in the 1970s. And the other thing that they did as part of their deal to make sure the elite, the medical profession were on side, was to privilege teachers. They had the best staff, relatively high levels of funding, and relatively more investment. So the way that played out is these are two contrasting places. I actually brought up here in the industrial decaying town in the north of England and moved for a short time to live in this leafy, very attractive, rich area of London, Hampstead. What we found in the 1980s was the exact inverse care, which is that the resources that Hampstead got per capita were 3 times the level of what they were in Oldham. So what we introduced was this method of formula funding, which is that we'd have a budget for England, we'd allocate that according to the size of the population on a geographical basis, and we also recognise we need to take account of age and sex. Now, you have a problem if you just take account of age and sex. This shows what we all know from age cost curves, which is that I'm riding up the age cost curve now. You know, once you get it, it's very low in this age, and this is the sort of retired population for different types of healthcare. This is the global figure. Now, this is a very famous finding quoted by Marx on this work on social determinants of health about these 2 areas in Glasgow, a few miles apart from each other, with this 17-year difference in life expectancy. Now, if you were to simply fund for age and sex, of course, what it would mean is that Lenzie get much more resources than the Colton, because no one actually lives very long in the Colton, and that's when you get the high levels of funding. So in the formula we recognised, and this has always been controversial, that we need to put in an element for need additional to age and sex. And broadly, the thing that follows there, well, it's contested, is we look at we look at standardised mortality ratios, the ratio of actual deaths in an area, to the deaths we'd expect given the numbers and age-sex distribution of population. So in the Colton, they'd have a horrendously high SMR, it would get much more funding, and in Lenzie North, they had a very low SMR, and they would get much less funding. The outcome of that has been, by following this process over from the late 1970s, is we have actually corrected the inverse care law. So if you look, this is standardised mortality ratio, it's quite good to take at the younger age, it's sensitively shown. And this shows the areas would be like the Colton, very poor materially, short life expectancy, high mortality. These would be areas like Oxford, Liverpool, Manchester will be up here, Oxford, which is where I live, is down here. So the northern industrial cities have something like twice the level of funding of the affluent areas in the southeast. So in a sense, mission accomplished in terms of an equitable allocation of resources. Now, what we understood was going to happen through moving money around in this way, in a relative term, is that we didn't think we were going to do anything to the health of the populations. We recognised that putting more money into healthcare wouldn't actually necessarily make the population healthier. But when I was put on the government working parties when the Blair government was elected in 1997, what ministers were troubled by is what they'd found is it wasn't just that putting more money into places like Oldham hadn't reduced their SMRs, it was that actually the SMRs were widening. So we actually had a widening of inequities in health between the rich and poor areas, whilst we're pouring much more money into these poor areas. So the work I did with Rio Fredrickson was to say, well, let's look at England and Sweden. This is a very interesting natural experiment. They're very similar in terms of a single payer system and structure. Of course, there are differences in local government, in healthcare being run through local government in Sweden and through the National Health Service in England. But in terms of access to healthcare, Sweden, being part of the Scandinavian model, has a much more commitment to an equitable society than England has since the election of Margaret Thatcher, which largely continued under Tony Blair with a statement by one of their politicians saying, we're enormously relaxed about the filthy rich, as it were. But in access to healthcare, because we have a national health service, we can direct resources to areas in need in a way you can't through local government. There's this question then as to how, when these come together, which one does better in terms of health outcomes? And this is evidence, this is Thomas Piketty's bestseller extraordinarily, the rock star of economics. There aren't many rock stars in economics, but he's one of them. And this shows what happened to the 10% income share over the last century, with it falling across in England and Sweden until the 1970s. Then this sudden shift in England, with Sweden continuing to fall up to a more equitable society, and Sweden being much more equitable than England. This is, of course, just one indicator of differences in outcome. Now, if we look at equity in healthcare, what we want to see in terms of spend per capita, as I showed happened to England, is something that looks like that. So the higher the SMR, the higher the level of spending. But if we look at list size in terms of patients per general practitioner, we'd want it to be the other way around, which is that we'd want GPs in very areas only healthy to have low levels of patients per doctor, and it to be much higher in the richer areas. This is what happens in England. This is the recent England one in 2009, which shows, this is the spend per capita I showed before. So we've made great progress in terms of equity there, as I said, but the GP one is just actually random noise. There is no statistically significant relationship between these measures of need and the distribution of GP. So it shows the limits of negative direction. It's much easier to move money around than it is actually to move doctors. But the thing I want to emphasise is this huge variation in the standardised mortality rates from 70 to 170. If we look at Sweden, this is spend per capita across local healthcare by local government. I think it's 2012, I think is the data. And this shows you have, of course, a process of equalisation, which means there's very little variation in spend per capita, but you do not have, as in England, a thing in which it goes like that. So you do not have a system which enables you to target more resources for healthcare where there's greater need. The GPs, if anything, that suggests there actually is an inverse care law in the list size tends to be higher where there's worse healthcare. But the thing that's particularly interesting is this incredibly narrow range you have in this measure of mortality, measure of health, between 85 and 110. So in England, it goes from 70 to 170, and in Sweden, it's that narrow range. And if we look at, of course, England's a much bigger country than Sweden, but if we look at the northern region in England, similar size to Sweden, we get a similar sort of wide range in SMR to what you have in Sweden. So, I mean, basically, it seems to be the story here, and it's a troubling thing for us in England, is whilst we're very successful in moving money to meet greater need in the population, there are serious questions whether that's a good use of public funds to put money into acute healthcare, where most of the money goes, to try and correct the inequalities in health we have in England. And the real solution, it seems to me, is to go to a more equitable society. I'm now going to talk about models of governance. I'll go through this relatively quickly, but I'm happy to take questions at the end. Basically, these are key figures in this. This is Thaler and Sunstein's written this very influential book called Nudge, that came out about 7 years ago about behavioural economics. This is my good friend and colleague, Julian Legrand, who's a big advocate of markets in public services. And this is David Hume, who talks about knights and knaves. Basically, this is the microeconomic case on this, which is Julian Legrand, being an economist, believes that you should have a system that treats people as if they are in microeconomics, and you have hospitals competing, and those who do well gain market share. You know, it's a much pleasanter place to live, and the hospitals who do poorly, they lose market share. The big difficulty we have is that we cannot have failing hospitals exit the market, but we know from both empirical evidence and theory that this is a key element in terms of getting the markets to work. Julian's argument is that whereas before Margaret Thatcher came into government, the assumption was that everyone who worked in healthcare were driven by trust and altruism, that the people who work in public services want to do the best they possibly can. And this assumes that they're not like microeconomics, they're humans, more complex motivations than in microeconomics models. But the German's argument is that people aren't really like that. They're a mix of selfish motives like knaves and altruistic motives. And this system of incentives plays to both, that if you work in a hospital, you should want to provide a fantastic service. And if you do, you get rewarded through the economic system. And if you fail to do that, you get penalised through the economic system. The trust and altruism model just thinks everyone's knights. And the big problem we had, which is what the Blair government changed in 2000, was what do you do if a hospital's failing to deliver services at the level it ought to, and outcomes at the level it ought to. And what we typically do in Britain is we reward failing hospitals. So the more you fail, you're given extra money, and those who do well are just completely ignored. The explanation for that is if you think everyone who works in these hospitals doing the best they possibly can, the failure must be due to external circumstances that give them more money to cope. Whereas, of course, it creates a system of perverse incentives. This is Don Berwick, who's argued that neither of these two models look to be particularly effective. The trust and altruism model, suppose you have information that tells you that your hospital has very high hospital-acquired infection rates, and you want to reduce that. The point he makes is, as we all know, changing what organisations do to achieve high performance is very difficult. First of all, you have to understand why things are the way they are and what you ought to do to improve. And as we all know, knowing what ought to happen and getting the organisation to change to do that are two very different things. So there's this tremendous inertia to improve under the trust and altruism model. Now, the choice and competition model is that actually you'd have a change in the market share, as Julian argues, that provide the external shock to overcome this inertia. But for that to happen, people need to be aware of differences in hospitals, know about it, able to choose and exercise choice. And the evidence from the United States is this doesn't happen. They don't know about the differences, even when they do know, they don't exercise choice. Systematic reviews show that, paradoxically, people do not switch from poorly performing hospitals to high performing hospitals. Famously, when the New York State published risk-adjusted outcomes for cardiac surgery, hospitals that had appalling rates, patients continued to go there and no changes in market share. The hospitals acted because they realised that the high rates reduced the surgeon doing very small numbers of operations, stopped them operating, but had no effect on market share whatsoever. So the market doesn't work very well. So the Blair government, in looking at how to change the NHS round from 2000, introduced these two brutal models to shape the NHS out of the state it was in. There's naming and shaming and targets and terror. So naming and shaming is about you put information out in the public domain to say these hospitals are failing. And the exercise I was in, I'll describe the star rating process. You'd identify the failing hospitals. It would feature in the national television news. It would feature in the national press. It would feature in local television news, and it would feature in the local newspapers. And when I had to deal, as I did, with chief executive hospitals that were suffering under this process, they would say how awful and unfair it was. And one of them said the thing she was dreading was the local newspaper at the weekend, which it would be full of how her hospital has not done well in this process. Targets and terror is a very simple model. Basically, you sack the chief executives who failed to deliver the targets to guards government, which was important. This is the clear. Both of these have clear sanctions. In this one, you damage the reputation of the organisation and those who work there. In this case, they're threatening people with a sack. This is a classic economic model. This is the one I am. What Richard and I were saying, that we do these things incur great hostility in audiences, and this is one that makes me deeply unpopular because I'm a great advocate of this kind of means of improving public services. And my argument is this isn't about microeconomics models at all, and it does play into the fact that the people who go into public services are you're going to healthcare, you go to teaching universities not to make money, basically. You go there because you want to do good, and you also feel that the esteem that you're held in, so people see you as doing good for the population. But this is what it's not out of driving a red Ferrari. Essentially, what I heard is if you apply for a job at Goldman Sachs and they ask you why do you apply for the job, and you don't say I'm coming for the money, you don't proceed to the next step. Now, clearly, when you apply to work in hospitals or schools or universities or government, you're not in it for the money. And what this process does is basically to make publicly available the fact that these people work in these organisations are not actually delivering a good service. So they shouldn't actually enjoy esteem for the jobs they do. These are failures. And this is a very, very powerful process. I've got a lot of slides got some slides that develop on that, which I'm not going to do because I'm short of time. So Richard did warn me in advance, and there's a nice view of that. So, but basically, the evidence is this is an incredibly powerful way of driving performance, and I think it's a much more promising way than these other models. This is Rousseau. This is studies. I'm skipping over these slides. I think it's going on as well. The problem is, if you have systems that are very powerful like this against measures, you will end up with gaming. So the problem is that the thing that isn't targeted, people will worsen performance in other areas. They'll hit the target, miss the point. I'll give an example of that. And people misreport and cheat. I'll give an example of that. I'm not going to talk about what happened. This is the natural experiment between England and the devolved government. From 1999, the governments of Scotland, Wales and Northern Ireland were given autonomy to decide how they would run their health services and schools. And England changed in 2000, these governments didn't, and we can compare the outcomes. So the background is Tony Blair's promise before they won the landslide in 1997, they're going to fix the National Health Service. 3 years later, the OECD produced this truly damning report saying how awful the NHS was. And Clive Smee, who was the chief economist of health at the time, said that he was privately told over the phone they could find no redeeming feature, anything good to say about the National Health Service other than it was cheap. This is the failure to deliver the promise of reducing. This is Frank Dobson, the then Secretary of State for Health. This shows numbers waiting for elective admissions over 6 months, 9 months and 12 months in thousands, and it got much worse over the Labour government in office. There were also scandals in hospitals and general practice. The government realised they'd failed, that they elected that the previous market of the 1990s had not worked. Their attempt to rely on trust and altruism and give the NHS more money had not worked. Lord Winston, a Labour peer, gave an interview on the 17th of January saying how awful the NHS was, and the way his mother had been treated and in hospital was truly appalled him. But he said what really worried him is when he spoke to his colleagues about how awful his mother had been treated in hospital, they said, well, it's the National Health Service. What do you expect? So Tony Blair, his special advisor Simon Stevens at the time, said it's the most expensive breakfast in British history. 3 days later appears on the Breakfast with Frost programme, because of course, given it's much used, but iconic nature of the National Health Service with Labour, a Labour government cannot let the NHS fail, he has to fix it. So he promises they're going to fix it, and the way they're going to do that is to throw money. This is television-based policy making, which tend to go unfor in England. You may go in for evidence-based policy. We make big policy choices in the middle of television interviews. And as a result of that, this shows the spend as percentage of GDP for the first 50 years, and this is as a result of the television interview, with money being thrown at the NHS like never before. Now, basically, the government said, well, if we're going to throw money at the NHS like never before, it has to transform its performance. So we're going to give up this idea of trust and altruism, which we've tried, and we're going to move to this mix of targets and terror, naming and shaming. And the devolved governments, basically, what the devolved governments want to do was not do what England did. This is the whole point of devolution. The whole point of devolution is you're now free to do something different. So they had this great thing here, which is they didn't have to change what they did, and it was made different from England. So it's a perfect answer for them. And this is much more popular than these brutal processes. So this is what the Blair government did, was this is the thing I was involved in from 2000, was they have a system of performance assessment, key targets driven by waiting times. These were our assessments of clinical governance from the quality regulator. There's a set of broader indicators in what's so-called balanced scorecard, and also if you did poorly you'd fail, and if you did well you'd be seen as high performer. So if you failed in these two levels, you'd be named and shamed as a failing hospital. If you did okay on them and okay on them, you'd be given 1 or 2 stars. And if you did well on all of that and reasonably well in clinical governance, you'd be known as a high-performing hospital. Now, when the results came out, the first set of star rating results came out in September 2001. There were 12 hospitals that were identified as failing hospitals, and they were called the Dirty Dozen. And the Department of Health organised a meeting for these unfortunate individuals. We're from the Department of Health, we're here to help you, was the line that's actually told with a straight face to these poor people. And I had to go to this meeting because I was heavily involved in the process. And this is actually, this is Rodin's sculpture of the Burghers of Calais, which really captures complete abject misery. And that's what these chief executives look like. When I was at the meeting, you could go in reception and you could tell which these people were. They looked, people I knew from before looked physically diminished. All of them looked like they hadn't slept for a month. The result had been out for a month. They'd been through absolute hell. A qualitative study showed, of course, these were at risk of losing their jobs. They wouldn't be looking too good. But a qualitative study by Russell Money and others found that when you looked at the people who worked in the hospitals, they felt this too very keenly. They didn't like being known they're working in a failing hospital. Now, I find this a deeply troubling thing to be part of, but this is what I've been doing ever since, really. It actually works, that's the thing. So this shows the waiting time elective admissions, and this is when the star rating regime kicks in. As you can see, this tremendous decline in waiting lists. There was a target, no one should wait more than 12 months by 2003, which happened, no one wait more than 9 months by 2004. When the process started, it would take you the target would allow it to be 2 years from seeing a general practitioner to actually being admitted in hospital elective operation. In 2008, they moved that period down to 18 weeks. So we've moved over this period of extra funding and this brutal process to transform the waiting time problem in the NHS, which had besieged the NHS since it started in 1948. Now, of course, you'd say, well, actually, of course, if you throw money at the NHS like this, you can do this. But we can compare England with the other countries. The black line is England. This is when the star rating process kicked in. This is numbers, percentage of people waiting more than 12 months. In England, as I said, by 2000, no one was waiting more than 12 months. These are the other countries. Money being thrown at them like never before, actually getting worse. Scotland having had a much better performance than England, as the extra money flows in gets worse. This shows that they did actually get better in terms of admitting people after they got to hospital as referral. But the time taken for a GP to refer to hospital got worse in these other countries, although it improved in England. One of the most, there's a problem. One of the targets they had was if you go to accident emergency departments, we used to have horrendously long waiting times. When my sons played rugby, and if we had to go to A&E after they'd had an accident, you'd take War and Peace with you or remembrance of things, but you were, or a sleeping bag. The government said we're going to have a 4-hour target. The problem was that the target starts from the time you cross the hospital threshold. So if a hospital had a very serious problem and an ambulance turned up outside, they'd say you can't admit the patient yet. This patient has to stay in the ambulance until we know we can clear this patient within 4 hours. And you ended up with queues of ambulances outside the hospital waiting for the hospital to say, yes, we're ready, you can admit them. And I'm told in one extreme case, an ambulance service erected a tent outside the hospital so the patients could wait in the tent and the ambulance would get on with doing their job. But one of the most striking examples of this, because of course in hospital performance waiting times is one measure, these are complex organisations. Ambulance services you'd think getting to life-threatening emergencies quickly is what they'd all want to do. And both England and Wales set up a target that 75% of these should be met within 8 minutes. And by 2001, both countries were a long way from that. England put this as part of the star rating process from 2002, and immediately see this huge leap in performance in England to hit the target. Wales failed to hit the target, and the government actually, the solution to that is to lower the targets. And if an English hospital service achieves 65%, the chief executive will be sacked as a failing organisation. This caused a scandal in Wales. But this is a very powerful example of how a performance regime can actually transform performance, and trust and altruism doesn't work. I'll skip over this. There was gaming actually went on in Finland, the figures. I just want to conclude with what I see as an important development in Italy's regions, because due to my friend and colleague Julian Legrand advising the Blair government, they shifted away from this model to the use of hospital competition and markets, and I would argue the evidence is not very powerful. This was effective. So whilst we had a very good system that worked from 2005 in the star rating system, they've then sort of shifted away from that. And the region that's done most interesting development of that is in Tuscany. And this is Sabina Nuti, is the director of that research. They've looked at different models. They've got a natural experiment in Italy across the different regions. I'm not going to dwell on that. They also introduced a system of pay for performance of rewards for the chief executives of the hospitals. But the thing I wanted to show you is this, what I think is this ingenious way they have of displaying complex information on performance. One of the limitations of the British system, the English system, is you have a single score for a hospital. So hospitals are identified as high performing or failing. But we know within acute hospitals, there's enormous variation in what goes on within them. So labelling a hospital as failing just doesn't capture its complexity and variations within it. What they do is they have this dartboard. This is the Italian for dartboard. So the red area means that you're failing, and then the green areas means you're doing well. And this shows Marquet, that's relying on the model of trust and altruism. These are a variety of different indicators, and this shows where you are on each indicator, and also give you an overall impression of how well you're performing. So you can actually compare the different regions. Another one relying on this uses trust and altruism. And this is Tuscany, which pioneered the system. And as you can see, they've got many more, much more of the performances in the good zone, none in the bad zone. So I believe powerfully in the example of naming and shaming. The evidence is you want to have a ranking system that's clear and understood. And this is a great way of doing that, capturing complexity of healthcare. So this shows the pictures of different regions. So my conclusions are, basically, for the three objectives we're trying to achieve, in terms of cost control, having government as a single payer is key, user charges is a distraction. In England, we've got a good way of formula funding to achieve equity of access, but it seems to me, from the discussion over lunch, you have a question of social determinants of health here, but you're much better at achieving equity of outcomes because you have a more equitable society. In terms of models of governance, I see naming and shaming as a very powerful way of doing that. It does generate high-powered incentives, so you have gaming, and you have to have systems of regulation to tackle that. Virtual economy. Okay, well, thank you very much.